So, hello, dear colleagues. Today, in this 4D 3.0 session, where we detailedly discuss and create a dialogue about Indian diabetes, that is the 4D 3.0 session. Today, we are here with three eminent doctors from the city of Bengaluru. So, first of all, I would like to introduce Dr. Tabit Ahmed, who is an interventional cardiologist. Good
Hello.
evening, Dr. Tabit.
Good evening,
Yeah.
Dr. Yashwant. Thank you.
So, Bengaluru is a city that you both love as well as hate. So,
Yeah.
what is it that you really love about Bengaluru, and what is it about that you hate about Bengaluru?
Love and hate relationship is there in Bangalore to a large extent. Yes, a lot of things to love in Bangalore, including the weather, the people, the opportunities, and the boom of IT and health sector and everything. What I might obviously everywhere we talk about Bangalore traffic. So that is why the session also got delayed today. I was stuck in in a gully somewhere before I could reach here. So apologies from my side for the delay. So that's what we do not like about Bangalore, the traffic, because the growth is vertical and not horizontal. So the traffic gets anyway
So,
congested.
other than that, it seems to be a perfect city. So,
Yes.
there was once upon a time where I think if you could gauge Indian cities in metabolic health, which is the topic today, I think Bengaluru would have topped the list. But today, I think it is in the worst metabolic health that you can talk about cities. So,
Totally.
talking about metabolic health, I would like to introduce next speaker, who is a diabetologist, Dr. Arjun Kalasapur. So, he's a diabetologist at Mohan's Diabetes Specialty Clinic at Basavangundi, Bengaluru. So, when we talk about health, what do you have a picture in mind, Dr. Arjun?
First of all, sir, thank you so much for the introduction. Yes, when I talk about health, like you were mentioning, Bangalore is becoming worse and worse because when I thought what we were seeing probably 10 years back in the 50, 60, 70 age group, now I'm seeing anywhere between 18, 20, 25. The entire demography with respect to health is changed. The complete metabolic health is changed. That is primarily what I'm seeing nowadays.
So I think that would be our discussion point. And for that, an important aspect of metabolic health, because metabolic health is always talked about in the terms of cardiac and a diabetologist or an endocrinologist perspective. But the oft forgotten part is the nephrologist perspective. And for that, I would like to introduce Dr. Sunil R., who is a senior nephrologist in Bengaluru. So welcome, Dr. Sunil. And a question that I would like to ask you is the same question that I asked the other panelist. So, what is it that you hate and what is it that you love about Bangalore? So, traffic has been told about hating Bangalore, but is there anything else that you hate about Bangalore?
Thanks for a nice introduction, Dr. Ishpal. Obviously, I think Bangalore, a while ago, probably 2-3 decades ago, it was called Garden City. I think all of you are aware. I think.
Absolutely.
So that, everybody used to come here, stay here, and obviously, as Dr. Tabit mentioned, the weather is very good. People who came here never went back, especially IT boom, which happened in 1990s and 2000. So those who have never gone back. But obviously, I think over a period of time, the population has doubled, tripled. So traffic is still an issue, and I feel it will be an issue in future also. I think government is taking all the necessary steps. They are doing everything. Probably, I think we should always see at the end of the day some ray of hope should be there. There is metro expansion which is going on all the places. So that I think there was a news also you would have heard. There was a tunnel road which was in discussion. So there were pros and cons for that tunnel road and all. So always we should see a ray of hope. That's all I feel.
So I think each and everyone has a story about getting stuck in the Bangalore traffic, and each stories are different. And it gets bigger and better, worse each time that we visit. So let's hope that it turns into again a index of metabolic health that it was earlier. So coming to today's topic, where we talk about metabolic health targets and technique. So the first question that I would like to ask Dr. Arjun is, what do you think, or how do you think we would define metabolic health?
So when we talk about metabolic health, primary, I would see metabolic health in terms of, let's say, first of all, I would say if in terms of disorders, if I have to classify diabetes, hypertension, dyslipidemia, obesity, and uric acid, and the Targets, sir, again, I would classify, if keeping the guidelines aside, age-related targets. So let's say if I see someone young, the targets will be stricter. And as the patient's age, probably the targets will be slightly milder. When it comes to the comorbidities, CKD, or let's say a CAD, again, the targets vary. So, but someone who is newly diagnosed, who's overweight, my primary point here would be target the weight. Probably then everything comes down automatically instead of the other way, this way.
So I would like to ask a question to Dr. Tabit. Now, all of us know that metabolic health per se is a critical determinant of cardiovascular outcomes. So, what do you think are the cardiovascular outcomes that you would suggest are an important part of the overall metabolic conundrum that we label it as today? So, something called as the CKM, that is the cardiovascular, kidney, and metabolic profile that we talk about whenever we talk about a diabetic patient.
Yeah. Now this cardiometabolic kidney and the CKM kind of a spectrum, it begins at a very early stage, and the like we talk about diabetes as octet of the pathology in diabetes, and all of these have a cumulative impact on the cardiovascular, major adverse cardiovascular events, whether it is microvascular or macrovascular. It's very common, and we are just redefining and re-looking at the spectrum in various ways. It's the same gamut of things that we are trying to rotate and having a better perspective of what is happening from within. And with respect to that, we are having more and more therapeutic modalities which we have access to because we are understanding all these pathologies across the entire spectrum. So we understand that it is not individual diseases which are manifesting by themselves and progressing by themselves. They are taking everything together and bringing problems in a big kind of volcanic eruption once a patient comes to us with an ACS. So one is that, and then one is accelerated progression of atherosclerotic disease that we see in
That's an important point.
not very well controlled metabolic parameters that we see in our patients. Along with that comes with sleep disordered breathing, which adds on to these metabolic dysmetabolisms. And then we look at fatty liver infiltration and metabolic fatty liver diseases. Coming back to cardiovascular spectrum, we do look at atherosclerosis, heart failure with preserved ejection fraction, accelerated atherosclerosis, and young atherosclerotic disease burden, which is getting more and more prevalent nowadays. Although we try to look away from these main disease contributing spectrum and look at various other rare things like COVID vaccines and other things, but then we have these very important disease with unmet needs that we have to attend to. Yeah, I'm not telling that you can prevent the patients totally coming to me by dealing with this, but then at least we can numb that effect and have a lesser severe or less critical kind of a picture when the patient comes to us.
So I think metabolic health, I think that's a good perspective that you are put forward. But when we talk about metabolic health, the step son or maybe a step daughter is the nephrologist perspective. So because everybody talks about cardiologist, everybody talks about endocrine and diabetes care. But why do you think, Dr. Sunil, it is important that nephrologists should also engage in the metabolic health component?
See, obviously, as doctors have discussed, see, diabetes, hypertension, or metabolic syndrome per se, they are all risk factors for CKD. So that, when we divide patients with renal disorders, we usually classify them into two priorities. Those who have already a risk factor like diabetes, hypertension, obesity, IHD, or those who are taking drugs.
Right.
So there are few aggravating factors like poorly controlled hypertension or a poorly controlled glycemic index, or those who have repeated urinary tract infection or obstructive uropathy, or patients who are taking over-the-counter medicines. So that when we look into these parameters, see, if you take diabetes as an example, there are around 40 to 60% of a diabetic patient ending up in diabetic nephropathy. So as India itself is a diabetes capital, so we need to identify the patient who are at risk. So that becomes more important. And when there is diabetes, obviously the patients will have other components like hypertension, hypertriglyceridemia, obesity. These will all play a role. So that as what I see is what we do in Bangalore hospital where I practice is it's a collective approach. So endocrinologist should be involved, a cardiologist should be involved, and a nephrologist should be involved. So in that way, we manage together so that we make sure the patient who is diabetic or hypertensive should be identified what risk factor he have and what aggravating factors he has. So probably once we identify those things, probably collectively we'll be able to manage the patient.
Right. So that's an important perspective that you told about, that just not looking at just through one lens. I think it is a multiple things that are together, and that should be focused on when we talk about metabolic health or metabolic targets, whatever you want to say. But just to put it in the right perspective, Dr. Arjun, I would like to ask you, what are the metabolic targets that you want to achieve in majority of your patients with diabetes? So if you just label it in the format of 1, 2, 3, 4, so what are the things that you would like to look at in your patients with, you would say that the patient is achieving a good metabolic health?
Sure, sir. So, with respect to, let's say, someone who's young, newly diagnosed, and let's say it's this one without any comorbidities, young patient, like what I was saying, our demography is changed. The lower, the better. So, preferably 6.5 or lower, even if it's less 7 or lower. That would be my HbA1c profile. When it comes to the
Okay.
dyslipidemic profile, it would be less than 70. But someone who's slightly older with let's say someone who's 75, 80, I would want to prevent the hypos over there. That would probably be a little bit more liberal, 7.5, 7.6. Someone with CKD issues or CAD issues, again, 7.5 would be the baseline. But someone who's
Okay.
young, I would want it definitely far lower. Yeah, that is
Okay.
what would be, that's how I would be working on.
So I think these are 2 points that you covered. So glycemic control with prevention of hypoglycemia wherever
Yes.
possible. And I think a good dyslipidemic target is what you would like to focus on. Is there something that you would like to also focus on, the central obesity or visceral obesity, something that you would like to
Yes,
talk about?
because yeah, definitely, because the primary driver, what I see with respect to what obesity today is insulin resistance. So this
Right.
insulin resistance itself is the primary cause of both the visceral obesity also. So yes, definitely, I would like to tell whoever wants in, and majority out of the 10 people I see, 9 are obese, and all come with insulin resistance, and all come with the entire metabolic syndrome profile. So they have everything. So there, I would ask them to cut. Primary thing would be cut lifestyle management. 90% comes through lifestyle management, and I'd at least ask them to spend 3 days to 4 days a week on strength training. Then I will enter the pharmacotherapy profile, because pharmacotherapy, like what sir was saying, you have a lot of parameters. But yes, this is how I would like to manage my patients.
Okay. And any mention about endocrine perspective to the metabolic health? You would like to talk about thyroid or?
Yes, when it comes to the obesity, rule out the other causes, predominantly thyroid and the other hormonal issues, the androgens and everything. Rule out PCOD in women. Rule out the other causes, but eventually, even let's say women also with predominantly Indian women also have PCOD, because that itself is a state of insulin resistance. So rule out the
Right.
other causes. If I find one, treat the secondary causes. But if this is the insulin resistance is the primary cause, try and concentrate on it.
So, taking a cue from here, Dr. Tabit, I would like to ask you that beyond these, what are the inflammatory markers or some blood pressure markers that you would like to say that this is equivalent to having a good metabolic health? So, would you like to keep some targets? Would you like to achieve some particular parameters that you would like to look at?
Dr. Yashpal, you're talking about inflammatory markers and blood pressure markers. So, could you please qualify, or bring us to an understanding
So,
that we are
yeah.
talking about inflammation
So,
in what perspective?
So,
Because
would you
screening
like to keep
wise,
some blood pressure targets to achieve metabolic health? That you want to say that particular this blood below if your blood pressure is below this, then that entails somewhere that you are in a good metabolic health, especially in patients with diabetes.
well, see, looking at blood pressure targets or treatment targets, from various data and literature that we have, we do not want elderlies to start dropping, uh,
Right.
and we do not want young people to be lax on their BP targets. So we are having this kind of a spectrum. So if a 30-year-old or a 40-year-old man comes to me, I will talk to him about his next 20-25 years of existence without much of a disease progression with respect to hypertension. So we will be having a stricter BP targets between 120 by 80 to less than 140 by 90. But if you have an elderly citizen and We mean if the elderly citizen is well kept and well preserved and hemodynamically stable and otherwise physically active, we do try to target below 140 by 90. But then if it is a little frailish individual and we suspect there will be risk of falls, we do not want to be so strict with them. And then we individualize our treatment targets and therapy targets for each of these patients. We also need to consider and understand that the central aortic pressures determine the perfusion pressures, not the clinic-based blood pressure assessment that we look at. We cannot target that and afford to have a central hyperperfusion. So our individualized target is for this hypertension and BP targets is very important. Guidelines are definitely there. We are going by guidelines. I'm talking about the targets based on guidelines only. But in our practice, we have to be very careful with our patients, and we are having an ever. Also, we are talking about younger people coming with atherosclerosis. Our spectrum of age is also widening. We are not in 30 or 40 years back where patients were dying at 55, 60 years of age. We are having more and more elderlies also coming to our clinic. So regarding that, BP targets are still individualized. We have guidelines of 120 by 80, 140 by 90, but we have to individualize our targets with that respect. There is also concept of systolic hypertension and isolated systolic hypertension, looking at peripheral vascular resistance. Are these markers of something which is fishy underneath? So look at those parameters also. You can't say BP is 130 and 140, but the diastolic is consistently above 90, and let the patient stay as such. So those are also markers of vascular inflammation and increased diastolic pressures and peripheral vascular resistance, and try to look at the comorbidities that the patient has come with. If it is isolated and nothing else is there, then lifestyle modification always is the first thing in all of these subsets. But then definitely look at each of these patterns and parameters, and look at the pre or coexisting comorbidities and target our treatment. Regarding inflammatory markers that you were just alluding to, that is another kind of a therapeutic intervention that we are looking at. But inflammatory markers, could you just qualify that on Dr. Yashpal? Because we do not really look at, apart from HSCRP, C-reactive protein and lipoproteinase, we do not really look at as inflammatory markers in our day-to-day routine screening and evaluation in our cardiology practice. But if you want to specifically ask about any such inflammatory markers, are we screening for it or looking for it, then please qualify it further, please.
Right. So I think inflammatory markers still, I think, pertain more for academic interest rather than, clinical interest. But they are a good way to judge. But these markers like glycemic target, blood pressure, dyslipidemia, I think visceral obesity are important. Equally important are from the nephrologist perspective. Dr. Sunil, I would like to ask you, what targets you would like to achieve for metabolic health in a patient when you talk about renal perspective?
Obviously, as nephrologists, we'll be looking into proteinuria. So if it's a diabetic CKD, we'll be looking into the albumin. If it's a non-diabetic CKD, we'll be looking into the total proteinuria which is happening. So the target is as simple as that. Lesser the proteinuria, lesser the kidney damage. So take example, a patient comes with 300 milligrams of microalbuminuria. Obviously, he has diabetic nephropathy. So we need to start drugs or medications. Probably we will discuss later, I think. So to bring down the proteinuria as much as possible. The same way, if a patient with a nephrotic syndrome or as a non-diabetic CKD, so he has a proteinuria more than 1 gram, 1.5 gram, we would like to bring down below 1000 milligrams, like below 1 gram. So proteinuria is the main thing which we'll be looking at. Second thing is the blood pressure. So as nephrologists, we'll be a little bit stricter on blood pressure control, because what happens whenever there is a decreased blood pressure, so the amount of intraglomerular hypertension is less and the damage to kidneys is less. So we'll be a little bit tight on blood pressure. So it so happens sometimes we titrate the dose of the drug so that until the patient has good control. So there are instances where we go up to 110, 120 beat. So our target will be less than 138. And third thing is the GFR decline. So that whenever a patient comes to us, obviously will be referred by a endocrinologist, physician, or a cardiologist. So already they will be in some stage of CKD, either they'll be in stage 1, stage 2, stage 3. So we don't want the GFR to decline rapidly. So if you take diabetes as a disease, the annual decline will be somewhere between 1 to 3 ml per year. So we don't want to go above like 5 ml per year. So if it's more than 5 years, probably we end up patient undergoing dialysis in another next 5 to 10 years. So that these three things I usually look into it. Obviously, you could take other consideration like obesity. If the patient is obese, we calculate the BMI, ask them to bring down the obesity, because obviously obesity plays an important role in proteinuric diseases, because there's an entity called as obesity induced FSGS, focal segmental glomerulosclerosis. So these are the additional things: obesity, weight reduction, lifestyle management. All those, like, it's like a part of universal management. So as an nephrologist, I'll be looking into proteinuria, blood pressure control, and a GFR. These three things I would like to highlight.
So I think that's an important point that you made, that it's important that we actually start calculating the estimated GFR and not just based everything on based on creatinine, because creatinine can either sometimes underestimate as well as sometimes overestimate what actually the kidney damage is. And an important point about urine albumin creatinine ratio excretion that you spoke to us about here. So a question that I would like to again ask you, that when we talk about EGFR decline, so what are the core techniques for optimizing this metabolic health? So what are there in your armamentarium that you would like to make sure that a patient who is diabetic, to achieve his or maintain his good renal metabolic health, what are the core optimizing factors that you would like him to focus on?
See, glycemic index like HbA1c below 7%, blood pressure below 130/80, and ACARB should be introduced as early as possible, taking potassium into account. And obviously, like of late, like last 2 to 3 years, we are having adding SGLT inhibitors for all patients, because studies have shown like last 10 years, patients who are on SGLT inhibitors, they have done better compared to non-patients who are not on them, especially with respect to diabetic nephropathy. And Pindrinone has come into the market since last 2 years. Like, I'm adding all the patients on Pindrinone, especially if the patient have added ACARB, and upon that they are having hypotension, or they are not tolerating, or we have reached the maximum dose of ACARB. I'm adding Pindrinone to those patients. So
Right.
this has become the core of treatment, like sugar being less than 7%, blood pressure control, one ACRB, SGL2, and Kerendia, means basically Pindrinone. So these three drugs I'm adding routinely. Apart from that, lifestyle management. So it make sure he maintains his weight, and especially if the patient has CKD, we ask them to take a low protein diet, low salt diet, low potassium diet, because they'll be already on the ACRB along with Pindrinone. Chances of hyperkalemia is more. So we ask them to take a potassium restricted diet, so that reduce their weight. So these are the things which are telling patient, and obviously it varies from stages of CKD, especially if the patient is CKD stage 3 or 4. His dietary management itself is totally different compared to stage 1 and stage 2. So
Right.
that's why, as I told, once the patient is been referred to nephrologist, first thing we do is we'll try to calculate his GFR, tell him you are in this stage of CKD. So because as we see, as the CKD advances, the metabolic parameters like calcium phosphorus abnormalities will be more common. Then we need to add calcium supplements or calcium-based phosphate binders. We need to add calcitriol. So those drugs become more important. So it all depends on the stages of CKD. But in general, these 5 things like sugar control, blood pressure control, and ACRB plus SGLT inhibitor plus Pindrinone, will be a core treatment management.
A small perspective that I would like to ask over here is, lots of patients, rather physicians, have a fear that when finerenone or probably SGLT2 inhibitor is added, there is slight worsening of EGFR. So, at what point would you say that no, the drug needs to be taken off, or the patient can continue taking the drug?
That's why, see, probably we need to add one drug at a time. See, especially if you take HCl2, the patient has urinary tract infection, obviously we need to start. So we make sure the patient is being screened for urine routine and with the culture along with the ultrasound before starting HCl2 inhibitors. So I usually try to add up to the stages of GFR 30. Okay. So especially early CKD 1, 2, and 3 stages, we can easily go ahead and add it. Especially later stages, probably 4 and 5 and all, tendency to hyperkalemia is more. So those stages, probably we need to try and taper the drug, or we need to take a risk-benefit ratio into the patient. Otherwise, we need to explain them. So tell them like, see, you're on the drugs which are known to cause hyperkalemia. Be strict on your diet. And if there are any symptoms of hyperkalemia, or if you have any symptoms, try to come and meet us immediately. Because what happens once we start on the ACE-ARB, they give a long-term beneficial effect. So obviously, all of us know it has a pleiotropic effect. So they are known to preserve the renal mass, whatever leftover renal mass. In fact, we call something as RRF, residual renal function. So these drugs are known to preserve the residual renal function, delay the progression of CKD. In fact, we see patients, their dialysis duration to go for dialysis being prolonged by 1 to 2 years once they are on these drugs.
So I think that's an important point that you made, that prevention of progression as well as deterioration is most important when you talk about renal perspective. Coming to the cardiologist perspective, Dr. Tabit, I would like to ask about what are the pharmacological interventions or lifestyle interventions that you would like to do to optimize a cardiac metabolic health of a person.
See, as our nephrologist, as a panelist has already mentioned, now the important molecule of SGLT2 inhibitors, that has come from the endocrinologist perspective back to the cardiologist, and we are being more proactive in initiating most of our patients with HFpEF and also HFrEF, heart failure with reduced ejection fraction and preserved ejection fraction with the SGLT2 inhibitors. So this is a molecule which is uniting all the 4 boxes which are there in my screen right now, actually speaking. So we are seeing a real advantage, real benefit, real outcome analysis also that we have with respect to heart failure, cardiodiabetes, disease spectrum, central obesity and adiposopathy, targeting even that, and as a cumulative effect, reflecting back on cardiovascular overall health and even blood pressure targets, and to some extent even sleep disordered breathing also getting better with that. Apart from that, as therapeutic interventions, we all depend on our friends from all of these boxes over here, so that we refer back for proteinuria, albuminuria. Nowadays in heart failure with reduced ejection fractions, especially below 45 or 50 EF, and we need the role of MRA, mineralocorticoid receptor antagonist, and we're looking at say proteinuria which is there. We directly try to introduce fineridone, making sure that the nephrologists are on board, looking at dysautocytemias, and also making sure that other things are already brought on board, and then we bring in these things. So regarding this and lifestyle modification are very important from our perspective, and rehab, cardiovascular rehabilitative approaches post ACS with heart failure, those things will really help the patient get back on feet.
So some studies, they suggest risk stratification based on using NT-proBNP and HSCRP. So of course, in Indian settings, affordability is an important point that we need to make. But do you concur with doing these in all the patients, or would you like to individualize in certain group of patients who are probably more prone for heart failure or something like that, for risk stratification? So who are high risk patients and who are low risk patients?
See, obviously patients who have at the very outset elevated NT-proBNP levels, they have an ongoing heart failure. And we look at those individual trends with these patients themselves. We do not compare this particular patient NT-proBNP with another patient NT-proBNP. So if the patient is on a follow-up with us, then we look at those NT-proBNP levels. Ideally, we have to follow up the NT-proBNP along with the symptomatology and look at the NT-proBNP trend and quantify the treatment response, not just subjectively with the NYHA classification, quality of life scoring and all of that, also with this NT-proBNP assays. But as you said rightly, the resource limited setting that we work in, we also have to look at plus minus whether we can do NT-proBNP on everyone. But ideally, yes, it is proven that way that NT-proBNP trends are declining when we introduce these molecules and other lifestyle and therapeutic interventions that we have. And to risk estimate the patient, always a constantly high background NT-proBNP levels are not a good marker for the patient in the long term. And definitely a steady increase in the NT-proBNP is another problem that we have to deal with. Every heart failure decompensation or acute decompensation of heart failure will get the patient to a newer, lower baseline, which I explained that to every patient with heart failure, that you come with the ADHF, then you are coming at a lesser baseline when you recover from that. Whether it is LV function, LV indices, the LV sphericity index, the functionality, and the long-term prognosis. And every time there's a rehospitalization rate, which again gets worse. Hospital, related mortality, all those things get worse. So those are the things that we with respect to this. With respect to inflammatory markers, that's also a poor indicator with respect to heart failure and the gamut of so many other things. Whether it is poorly managed metabolic spectrums, the inflammation is also an important aspect where we look at this. HSCRP is a risk marker with respect to inflammation. But again, coming back to therapeutic modalities, when we look at these things, what therapeutic modalities can we offer to our patients which are available, affordable, and whether we can continue those things, including
Absolutely.
in one targeting therapies.
So I think, Dr. Arjun, I would like to ask, they spoke about pharmacological interventions, but I would like you to speak about two main perspectives that are there in our hand. One is the availability of GLP-1 analogs, and also I would like you to talk a little bit about exercise as a modality for probably optimizing your metabolic health.
Sure, sir. So primarily, before I come to the pharmacotherapy, the exercise is the primary modality, sir, because lifestyle, once we are able to correct the lifestyle of the concerned individual, he or she, then only the pharmacotherapy helps it. So when it comes to the exercise, so people say what. So more than the walking, something we say the strength training, the resistance training is what we tend to stress on. So even if there is a paucity of time, so there are studies to prove, enough studies, thrice a week or 4 times a week of 30 to 40 minutes of strength training, and will help in not only the metabolic health, and when it comes to the heart health, let's tell them 6,000 to 8,000 of steps throughout the day is going to help in their heart, is also going to help in their other parameters also. So strength training will be the primary driver, bringing down the insulin resistance also, because giving them strength training, the insulin absorption definitely improves. So obviously the sensitivity of the insulin improves, bringing down the resistance. Then in addition to this comes the GLP-1 analog, because primary driver as of now, sir, especially in our young patients, is obesity. And this is mainly because of the insulin resistance. And again, insulin resistance being the primary cause of hypertension, fatty liver, and that's where the GLP-1 comes, because there are enough studies to prove it. Especially we have the dual agonists, we also have the single agonist like the semaglutide. Now we have the dual ones like the triziprotide, that's the Mounjaro. So with respect to the side effect profile, haven't seen much, but yes, sir, primary in our practice, what the protocol we follow is the retinopathy. The baseline retina is what I look out for, because that's the apprehension with everyone who are, before they ask any issues with the retina. So once the retina is clear, we can go ahead. Then yes, so give them a choice, because the only difference I have seen with respect to the dual agonist and the single agonist is the dyspepsia, which I don't see much with respect to the Mounjaro, which I see slightly more with respect to the semaglutide. So that's probably because of GIP-1. But yeah, and since they also have studies which prove they reduce the incidence of MACE, they reduce the progression of the CKD also. They also, semaglutide for now is also been approved for NAFLD also. So by doing this, we are able to predominantly improve the quality of the life of the patient. But yes, cost is one more thing we need to, apart from the dyspepsia and the other side effects, like the pancreatitis is very rare. Retinopathy, since we're doing the baseline, cost is something which we need to discuss with the patient. If they are on board, we can definitely go ahead. So GLP-1 is definitely a good intervention. But yes, again, and reduction of carbohydrates. So that is one more thing which I also expect along with the exercises. So this is how I try to manage.
So I think most of the parts has been covered, where we talked about the lifestyle interventions, right from reducing the sodium to optimizing the protein, bundling up with SGLT2 inhibitor, GLP-1 analogs, using mineral receptor agonist, then adding on RAS blockade like drugs, using finerenone like drugs. You also spoke about exercise. A point I would like to add over here is, I think we also need to make sure that our patients sleep well. That's an important parameter that is very optimal, because I think circadian rhythm is very important. And there was a recent study which highlighted that nearly 40 to 50% of Indians on weekdays just sleep for 4 hours. I think that's not more than enough, because probably in metropolitan cities where you need to take a lot of travel time, you have to handle logistics, you have to look about everything. I think that's an important factor. And surprisingly so, even the younger adults as well as children are sleeping less. So I think we need to emphasize that we make sure that our patients, they sleep well. So this actually surmises something that are the targets that we need to optimize about. So I think before moving out, I think there are some cases that I would like to discuss. So first, I would like to start with Dr. Sunil, where we talk about some short case study or case scenario, where you can suggest the ways where we can optimize the way with which we can look at this particular case. So this is a 50-year-old male with type 2 diabetes, hypertension, and BMI of about 33 kilogram per meter square, and his albumin creatine ratio is about 180 milligram per gram with EGFR of 64, A1C of 7.8, and he actually reports fatigue and nocturia with a blood pressure of 144 by 86. So I think what would you like to have a plan of action in place for such an individual? Dr. Sunil, please.
So as you told, the GFR is 64 ml. So he is in stage 2 CKD. So
Right.
and he has some poorly controlled diabetes. So then BMI is somewhere around 33. You told, if I'm not wrong, correct? No, 33.
Right, absolutely, 33.
So that he's overweight. I mean, it's like grade 1 obesity. So
Right.
that in fact he has all risk factors for metabolic syndrome and poorly controlled diabetes. So first
Right.
of all, I would like to control diabetes. Can I know what diabetic drugs he's on?
Yeah, so he's probably on just metformin and sulfonylurea.
Probably, I think I'll do a urine routine and ultrasound. Since you are telling there is nocturia, I would like to see if there is some infection. If there is no infection, definitely SGLT2. Like you should be able to add a SGLT2 so to control his diabetes. And what is his blood pressure? I just
Blood
forgot
pressure
that.
is 144 by 86, and he's just on amlodipine 2.5 mg.
He is a candidate for a ACARB, so we can start him on a ACARB. What I would like to do is I'll start on a low dose, like for example, telmisartan or a ramipil lowest dose, like ramipil 1.25 mg or telmisartan 20 mg, and monitor his blood pressure. Like call him weekly once, check his potassium. If he's tolerating well, I would like to double the dose, like 20. I'll make it 40 or 20 BD, then I'll make 40 BD, like that, until otherwise he has hyperkalemia, and as long as the creatinine is not doubling up. So we usually expect a rise of creatinine around 20 to 30% once we start ACARB. But as far
Right.
as possible, if there is no decline in GFR or there is no rise in creatinine more than 30%, I would like to continue ACARB. So BP, I would like to bring it down below 130/80. So at SGLT2, I'll add up. So that, and if he develops hyperkalemia or if he's not tolerating ACARB higher doses, then probably I would like to add fenbrizone also. So, but all
Okay.
this will be done over a period of weeks, not at one shot. So
Okay.
that, and what is his lipid profile? Like
So
he's looking like.
yeah, so he does have dyslipidemia, and LDL value is somewhere around 160.
Obviously, is a candidate for statin. So that we as nephrologists, we usually give lower dose of statins because higher dose usually can cause interstitial nephritis. Like unlike 40,
Right.
80, like how cardiologists use, we usually start at 10 mg. So that
Right.
we usually start at the lowest dose. Then I'll ask him to go for a lifestyle modification where he can bring down his weight. Obviously, that will help him. Then
Right.
dietary modification, since he's already in CKD stage 2, I'll ask him to take a low salt diet, 2 grams per day, low protein diet, 0.8 gram per kg body weight. Then ask him to restrict fluid to 1.5 to 2 liter per day, and make sure he gets necessary vaccine because since he is already in CKD stage 2. What was his age?
His age is 58.
Okay, see, you should be vaccinated for a pneumococcal vaccine, and influenza is there right now everywhere. He needs the influenza
Right.
vaccine, and if he is affordable, we should obviously give him a Shingrix vaccine also. So vaccination part, I would like to take care.
Right.
So further so cardiovascular evaluation obviously needs to be there because cardiologist
Right.
is with us. So and fundus needs to be looking whether he has diabetic retinopathy, as endocrinologist has told. So these
Right.
things, as nephrologist, probably I'll look into it. And if there are issues with respect to cardiac, obviously I'll be taking cardiologist opinion, and I would like to consult and ask endocrinologist opinion regarding the diabetes control.
So, any views that you have about using fenofibrate in patients with CKD? So,
No, if the triglycerides were very high, like somewhere above 500, then I obviously will use it. But less than that, I usually ask them on statins because his sugars are not controlled. Obviously, that can cause hypertriglyceridemia.
right.
So that statin should be able to control, and we need to see his dietary means his habits. If he's alcoholic, probably we need to cut down on alcoholic because that itself can cause hypertriglyceridemia. So that usually if it's above 500, usually we won't start it.
Right. So I think that's a complete fair perspective that you have put on. So I think SGLT2 inhibitor still stands important. RAS blockade still stands important, and lifestyle modifications is something that you need to look at. And add-on would be a finerenone-like drug that would definitely help in such a perspective. Coming to a second case where I would like to ask Dr. Tabit. So we have a 55-year-old male with a BMI of about 32 kilogram per meter square, and he is hypertensive. He has dyslipidemia with LDL-C about 160, HbA1c 7.8, EGFR again 65. He has exertional breathlessness or dyspnea of NYHA grade 2. So, what are the plan of action that you would like to be on? Suppose, say he's just on a sulfonylurea and a metformin.
See, now we are obviously you involved me because there is also a breathlessness over there on exertion.
Right.
I mean, we will be digging on that ground definitely. Now coming back to his dysmetabolism, we will have to target his LDL levels, we will target his HbA1c, his obesity, and his hypertension. So
Okay.
again, the same gamut of discussion what Dr. Sunil had put forth. We will be looking at all of those things, and I mean, from the Indian perspective, we will be looking at predominantly central obesity only, not like European kind of a physique. So we will be
Right.
looking at bringing in SGLT2 inhibitors, getting the BPs normalized, starting LDL lowering therapies, including statins, and HbA1c reduction with SGLT2 inhibitors as an add-on. Looking
Okay.
at his risk of UTI and overall health, and definitely because he's getting some breathlessness, and I mean, you said the age is around early 50s or middle age.
55, yeah.
Yeah. So we
55.
will be obviously looking at the cause for these breathlessness, whether there's heart failure with preserved ejection fraction or there is coronary artery disease coexisting, because it's a very common accompaniment, and these are all CAD equivalents that we're dealing with as comorbs. So we'll do a stress cardiac evaluation either by way of a treadmill test or dobutamine stress echo or a stress MPI, and take things forward based on what we see, whether the patient needs any revascularization strategies from that perspective. We'll be starting antiplatelets. Maybe I would look for the stress cardiac evaluation and then look at antiplatelets as an add-on.
Okay. Do you think there is any role of ARNI in such patients?
Now, you said we don't have the picture on the LV function or the LV ejection fraction. We don't have the echocardiography right now with us. If the echocardiography shows that the LV function is poor, then we have to really look at this picture, whether it is ischemia or non-ischemic cardiomyopathy. Definitely RNA comes into the picture, but all of those things again go into a different pathway. But yes, RNA comes into the picture, especially with FRF, LV function, moderate to severe LV dysfunction.
So I think that's an important perspective that you put in. Again, you stand the same what Dr. Sunil said, that I think SGLT2 inhibitor still stays an important part. RAS blockade still stays an important part. And these are drugs that are time tested, used for a long time. Optimization of weight with use on probably GLP-1 analog whenever necessary. And utilization of statins, antiplatelet drugs, and add-ons with ARNI-like drugs whenever you actually are looking at optimization for heart failure. So I think coming to
dealing with the possibility of coronary disease or heart failure, we should not forget putting in beta blockers in these disease patients.
Absolutely. So any particular choice of beta blockers that you would like to suggest?
If there is a heart failure kind of a precedent, we generally look at cardiac beta blockers. And the classic, possibilities that we look at: carvedilol, metoprolol, bisoprolol. So these three are the most commonly prescribed beta blockers from our perspective in heart failure and coronary disease. Although yes, we also use nebivolol in varied extents, but commonly we use carvedilol, bisoprolol, and metoprolol.
Okay.
In our practice.
So coming to our third case that we have today. So I think this is with Dr. Arjun that we are going to discuss this case with. So we have a 39-year-old female with obesity, BMI somewhere around 37, and she's pre-diabetic. So HbA1c is 6.2 with dyslipidemia, LDL of say about 160, She also has mild obstructive sleep apnea like symptoms. She also has associated irregularity in menses, and she complains of low energy, recent weight gain, some failed dietary attempts that have been done to lose weight. She has been diagnosed to have PCOS. She actually needed treatment to conceive, and she underwent treatment after following multiple IVF cycles. So she has received multiple hormonal treatments for that in past. So, what are the things that you would like to optimize in such a group of patients, and what are lifestyle things that you would like to offer, and pharmacological interventions that you would like to offer?
Sure, sir. Yes. So in this case, 39-year-old female, like you were discussing, PCOD, straight away insulin resistance. So this insulin resistance, PCOD, also her sleep difficulties, because I'm thinking the sleep apnea, because again, because of the obesity itself. So these two things. So in her case, pharmacotherapy will be there, but when it comes to the lifestyle, definitely, and the fertility issues, that's also because of the PCOD, that being the most common cause of the female infertility nowadays. Also the youngster, what we see here. So yes, the lifestyle, I would say here, please reduce the weight by primarily reducing the carbs, because here what we see, people, they love their rice, they love their chapati. So I don't tell them reduce it too much. We expect them to reduce it by 5%. So reduce the portion control, reduce the carbohydrates by 5%. That itself is going to reverse her insulin resistance. So once we are able to break the resistance, her hormones improve, her cycles improve, her weight reduces. So once her weight reduces, automatically her sleep patterns get better. So
Right.
once the sleep pattern gets better, automatically her quality of life definitely improves. This by reducing carbs, and probably, sir, her fatigue in this case, yes, weight, and generally, if I say, see, I'm not sure about her dietary aspect. So let's say if she's a vegetarian, what we see here is the protein deficiency, which is the more common cause of the fatigue, or could be because of the thyroid issues that also could be leading into the fatigue. The weight gain also could be because of the PCOD and the thyroid. So correct the, if there's a protein deficiency, probably just up it, pre-diabetic, give her a protein-rich diet. Correct the thyroid if it is there, so her cycles also will be in check. And finally, when it and the exercise aspect, yes, she requires minimum lot 4 to 5 days of strength training along with the cardio, the what we say, the walking or the treadmill, something like that. And when it comes to this one, the pharmacotherapy, in her case, GLP-1 would be my first choice, provided she's affordable, because I think she's got collective issues over here. She's got fertility
Right.
issues, she's got sleep issues, she's got insulin resistance, and GLP-1 as a whole, and the dyslipidemia also, again, could be because of the thyroid or could be because of the weight per se. GLP-1 will address everything. So bringing down the insulin resistance brings down her weight, improves her metabolic profile. Eventually, her quality of life will definitely improve. But one thing which I would like to mention to her also, she's young, so we can't put her on a GLP-1 for a long term, because we do not know. So because also at the same time, probably 2 years, 3 years, but make sure she knows once we stop the drug, her lifestyle should continue, because otherwise she'll have a rebound weight gain. So that's
Right.
because the people who come to us, they think it's a life savior, because it can't be lifelong. So young, the older patient, yes, we can give it 60, 70 years, but someone who's 25, 30, 35, 2 years, 3 years. But tell them once we stop, and it applies also. So one more option here could be the bariatric surgeries, what we see also over here, the surgeries which we do. But even then, after there are studies to prove, both with respect to the GLP-1 and the bariatric, after 2 years, if the lifestyle is not followed, there's a rebound weight gain we see, which is far more higher than what their normal weight was. So this is what I would like to
Absolutely.
manage this lady as a whole.
Any target weight that you would like to discuss with her? Because what happens is patients are given such humongous numbers in weight reduction. So if the
Yes,
patient is 100 kgs, they are told that you need to come down to 60 kgs. And
yes,
the moment they hear the number of 60 kgs, I think it is off-putting and they completely quit. So they think that it is so something that you would like to give, or some important target that you would like to give in this patient, where you can,
patient, yes,
that they would be happy and it would be a win-win situation for both the doctor as well as the patient.
yeah, so there's a primary here. So for someone who's obese is to keep them motivated. So because generally they would have tried it. This particular lady has tried all the dietary measures, nothing. So she's already demotivated. So instead of telling her like what you said, bring down the weight immediately. What, let's say small victories. So let's say I see you in 3 months, get me 2 kilos, 3 kilos. That's your first start. Then from there we'll go on. So eventually, once we reach a certain goal, she's around, I'm not 100 kgs plus. So let's say first, let's say we
Yeah.
target around 110, then 100, so on and so forth. So let's take it slow, but give her a long term goal. 2 years is your target. Post which,
Right.
then let's how it goes. So instead of doing it a short term, long term is what I would want to look at.
Right. So I think that's an important key message that you told. That I think there's one small saying in Hindi which says that "boond boond se sagar bharta hai." That means a small drop in the ocean comes to accumulate, and then I think the whole ocean is filled. I think same things are important that we need to take it home from here. So I think that nearly comes to the end of our talks. I would like to ask each of you. So what are the checklist points that you would like a physician to see whenever you are talking about metabolic health? So first, starting from Dr. Arjun yourself, where what are the checklist points that you would like to look at when you say about metabolic health?
Yeah, definitely. First would be the obesity, the abdominal obesity, the visceral obesity, the first one. Apart from that, the glycemic profile, the dyslipidemia, the other hormonal causes, the thyroid and the androgens and all the other parameters. And again, come back to her, even her blood pressure. So these would be the 5 things which I'd want to look at and then start going. This is how I work up someone who's with respect to the metabolic profile. And of course, followed by the cardiovascular and the renal profile also, which, yeah, this is how I would work up the initial aspect.
So that's an important point that you have made. But again, I would like to ask Dr. Tabit that what are the drug-wise checklists that you would like to see to maintain a good cardiac metabolic health? So which drugs do you think that the patient should be on when we talk about maintaining his cardiac metabolic health?
Again, if there's no pre-existing or diagnosed CAD or heart failure, the drugs list would almost be the same what an endocrinologist or a nephrologist would be bringing in. Only in the presence of HFrEF we bring in ARNIs or with respect to heart failure and coronary disease beta blockers. Apart from that, whatever drugs we discussed this entire session will be the usual that we look for. SGLT2 inhibitors, ARBs or AC inhibitors, statins as a first line for LDL lowering. As Dr. Sunil rightly said, we do not target triglycerides with phenofibrates until they go beyond 500, provided other metabolic parameters are addressed, including thyroid and diabetes and liver. Apart from that, also any comment on usage of saroglitazar in fatty liver infiltration with our metabolic kind of a dysmetabolism that we see is also welcome. Although we are running out of time, it's almost 53 minutes. Or maybe on another session we can look into that. So there's a common drug list that we are looking at all the 4 boxes and wonderful, beautiful faces despite late evening that I'm seeing now. Only thing is that heart failure and CAD we bring in beta blockers and ARNI.
Right. So last checklist from Dr. Sunil, that what you would like to suggest, and what is it that physicians do tend to miss? You would like to highlight that it's important that we keep in mind that we take care of those.
I think both of them they are summarized. As a nephrologist, I want physicians make sure all the patients are on one ACI ARV, whether they are diabetic or non-diabetic, because they'll have some proteinuria. So obviously they don't have multiple effects. So cardiac remodeling, renoprotective effect, other effects like LV remodeling, anti-atherosclerotic, all those things. So I tell all the physicians, you put them a small dose of ACRB, that is going to be beneficial. Obviously, they have summarized the other drugs and all, and make sure you check the patients on creatinine and urine routine regularly, because they tend to do only sugar, so that sometimes they end up missing proteinuria, like probably diabetic nephropathy or a non-diabetic kidney disease. So you just add creatinine and urine routine into your profile when you screen the patient. So obviously, if there is a rise in creatinine, you will be requiring my help or my suggestion. So if it's not there, then it's basically you'll be managing on your own.
So I think, thank you. And I think that really was a detailed discussion as well as dialogue about Indian diabetics, and the perspective that we spoke about today was about metabolic health, the target as well as the parameters, and how to optimize the health. I think I would like to extremely express my thanks to Dr. Tabit, Dr. Arjun, as well as Dr. Sunil to give your important time, because this is something that is going to be valuable for most of our colleagues who would be later on hearing this session. And thank you very much. Thank you.
Okay,
Thank you.
Thank you.
Thank you.
Thank you.